New York's classic rock, Q1043.
I say good morning to Munir Ghesani. He is the chief of nuclear medicine at Mount Sinai in New York City. And those of you who are familiar with my story, that's my hospital. That's where I went for my treatment for breast cancer. And I am just the biggest supporter of Mount Sinai Health Systems. And he's also the new president of the Society of Nuclear Medicine and Molecular Imaging. Okay, first let's tackle nuclear medicine. It sounds scary as hell. What is it in reality?
So in reality, it is by no means any scary concept at all. It is a simple concept of using small amount of radioisotopes to guide diagnosis and treatment. And unfortunately, this concept is not so common of a household name in general public, but in medical community, it is very well known that nuclear medicine is playing increasing role in early diagnosis, playing even increasing role in actual administration of targeted treatment. So I have no doubt that the way the progress is being made, that it will become a household name in 2 to 5 years from now, if it is not already in many households. As you mentioned, if you have been through a care where you had to use nuclear medicine in your clinical care, then you certainly recognize that it is something that is very pivotal in the clinical management of patients.
Let's talk about the latest information, which is how it's being used with COVID.
Yeah, so we just recently finished our annual meeting, which was in Vancouver last month, and many new abstracts were presented. One of them was showing how effective the our nuclear medicine imaging. In this particular case, it was using radioactive glucose and using PET-CT imaging to see what happens in the long haul COVID-19 patients. So there are about, in that particular study, what they found was that about 25% of the patients who initially had COVID had lingering symptoms, and they underwent nuclear medicine imaging with PET-CT. And then it showed that they had chronic sequelae of COVID-19 in their lungs, which correlated with their symptoms. And when these patients were treated appropriately with drugs that targeted inflammation and scarring, that these patients improved, which was shown on the follow-up PET-CT imaging, showing that their symptoms improvement correlated with what we saw on our scans.
But these were findings that you could not find on regular scans?
So the regular scans may show some scarring, but if you add the component of radioactive glucose using PET-CT instead of CT alone, it actually showed that that inflammation was active. And it is the active inflammation that gets targeted with treatment, which can subsequently show the improvement on the follow-up scans.
Also, you had some new findings about sleep apnea, which were very interesting.
Yeah, so that study was also presented at that annual meeting. And what was found was that when people were studied in a sleep lab, those who were suspected of having sleep apnea, when they had severe symptoms of sleep apnea or the severity of the disease was picked up on that lab study, they also underwent what's called myocardial perfusion PET imaging, along with what we call quantitation. So it's a very sophisticated exam that looks at precisely the amount of flow that goes to each part of the heart. And what they found was that when patients have severe sleep apnea, the small vessels of the heart were not receiving enough blood supply. And what is fascinating about this study is that if it is pursued with more patients and more advanced follow-up of these patients in the future, it can really guide the decision-making on why some patients with severe sleep apnea start to get the heart disease. And the reason we think, based on this study, is that when they have severe sleep apnea, the heart is not receiving enough blood supply because of the small blood vessels are not delivering enough blood supply to the heart.
So was this rather surprising that there was a link between sleep apnea and heart disease?
Yeah, it is surprising. And this is one of the pioneering things that our nuclear medicine imaging can do. Unlike other scans, nuclear medicine can actually look at the pure, what we call quantitation. So if you do a scan and then if you deliver your region of interest around the scan, it can tell you exactly what amount of blood flow is going to the heart, or for that matter, any other organ that you are studying. And this is something that is being increasingly recognized as very important in some of the decision-making. For example, if you have somebody with a coronary artery disease, those who get the heart attacks, those who have bypass or angioplasty to treat, those are big vessels. And there are many imaging studies that look at big vessels, including coronary CT angiography, for example. But none of those studies can look at small vessels that actually deliver the flow to the precise part of the heart. And this is only possible with techniques like PET imaging that can shed the light. So it is kind of surprising, but it is some of the evidence that we are seeing that in the future, more and more of these discoveries will be possible because of the strength of nuclear medicine techniques.
So at what point is nuclear medicine used diagnostically as opposed to a regular scan? Because most people are not getting these nuclear medicine scans, right?
No, that's actually not really accurate, because if you look at the number of nuclear medicine scans done every year in US, they are in millions. And the reason why people don't recognize is that, and I have had some casual conversations with people at social events, and when you talk to them about nuclear medicine, they would say, well, what exactly is that? And then I start describing some techniques, and suddenly I say, well, did you have a treadmill stress test, for example, myocardial perfusion nuclear medicine stress test? Oh yeah, I had it before my angioplasty. So what is really a missing link here is that it is being performed very regularly, in fact, as I mentioned, in millions, but people don't associate what the test they got done with what is that nuclear medicine component. So I think our job as nuclear medicine professionals is to really create that awareness that this is a technique that is used every single day, whether in the hospital or outpatient setting, but you need to associate the test that you got done is part of what nuclear medicine does.
I am speaking with Munir Ghesani. He is the chief of nuclear medicine at Mount Sinai here in New York City, and newly named the president of the Society of Nuclear Medicine and Molecular Imaging. I'm sorry, I heard about the loss of your father to pancreatic cancer during the pandemic.
Yeah, actually, it was a prostate cancer, but yeah, it happened during the pandemic. And my father had prostate cancer diagnosed about 15 years ago. And he was a big fighter. He fought through the various modes of treatment, including chemotherapy, radiation therapy, multiple surgeries, and hormonal therapy. And when the disease was very advanced, we in fact looked at having nuclear medicine potential for him. So what we do in nuclear medicine is that now it is becoming an increasingly common concept where we can actually treat the disease that we see, and we see the disease that we treat. This is very unusual and very unique to nuclear medicine. For example, if somebody gets a chemotherapy, there is no way to know exactly where that chemotherapy went. But if you come up with what we call theranostic pair, meaning there's a diagnostic component and there's a therapy component. So what we do is we do a diagnostic scan first. Look at the expression of the targets of, let's say in this case, cancer. Is our scan showing up where the cancer cells are? And if our scan shows the uptick in those areas, then we can just switch out the part of the radiation that instead of diagnosis now can treat. And that's so unique to nuclear medicine that when my father's cancer was advancing, me and my sister, who's also a nuclear medicine professional, she actually practices with me here at Mount Sinai, we both explored the possibility of giving him the benefit of this concept. So we got his scan done, and unfortunately, his cancer was one of those rare 5% of prostate cancers that don't express what we call PSMA signal. And as a result, he was not a candidate for that treatment. And so otherwise, he would have benefited from this particular treatment, which could have helped him in extending his life and also quality of life. So what we are finding is these treatments are not only prolonging the life, which various studies have shown, but the quality of life is considerably better compared to other treatments. So that's one of the big advantage of nuclear medicine techniques.
What would be the side effects of nuclear medicine treatment for prostate cancer?
So interestingly enough, but now we in fact at Mount Sinai joined what we call the managed access program or expanded access program. And so this was before the approval that came in March of this year with the prostate cancer treatment. So we now have treated more than 40 patients, and we had the firsthand experience of what actual symptoms occur. And surprisingly enough, symptoms are relatively mild. So they feel some fatigue, they feel some nausea, which is often manageable. And then on the long run, you have to make sure that you continue to monitor the blood test, because the treatment can result in the lowering of the blood count. So it can have the effect on the bone marrow. Majority of the patients usually recover with some initial drop, but some patients may have more prolonged decline of the blood cells, which is precisely what we have to watch carefully.
Is nuclear medicine being used to treat other cancers?
Yeah, so prostate cancer approval just came in 3 months ago. The other approval, which came in for neuroendocrine tumor, has been approved for about now 4 years. And I believe you know very well your previous guest, Josh Mailman, who you interviewed a few months ago. He, in fact, was one of the recipients of this treatment. And as you know, Josh is a strong advocate of this treatment, and he's a very close partner of SNMMI in a patient advocacy group. In fact, this afternoon, Josh is coming as virtually to Mount Sinai, giving his grand round presentation. And so neuroendocrine tumors treatment got approved about 4 years ago. And there are many other treatments that are in the pipeline. And so no doubt in the future, more and more patients will benefit from these treatments, and that will help in making the name of nuclear medicine or recognition of nuclear medicine as a household name.
What made you decide, you and your sister, to go into nuclear medicine?
Yeah, that was very interesting. My pathway was not straight. I was first in the internal medicine residency, and I was being selected as a chief resident, which would then subsequently leave you the option to become a cardiologist. So I was in line to be a cardiology fellow. And as part of my responsibilities, I was supposed to invite various speakers to come and give us a cardiology grand rounds. One of that speakers was Gordon Dupuy, who is a pioneer of nuclear medicine techniques. He, in fact, was the chief of nuclear medicine at St. Luke's Roosevelt Hospital on the west side of New York, where I ended up getting selected as his resident eventually. So he convinced me during an hour of lunch after the grand rounds to consider nuclear medicine as a field. Otherwise, I was destined to become a cardiologist.
Interesting. So we just have about another minute left. What have we not touched on that you would like to impart to our listeners very quickly?
Yeah, so our goal in Society of Nuclear Medicine and Molecular Imaging is to really have patients and their family members partner with nuclear medicine. So we want them to be the advocate of nuclear medicine. We currently are encountering some of the hurdles which will prevent the progress of nuclear medicine. So for example, all these new innovative drugs that are being introduced for clinical care, unfortunately, their reimbursement is only covered for first 3 years. And then they get packaged as supplies. And so that causes a major, major problem with ongoing reimbursement and ongoing clinical applications of these techniques. So currently we have in Congress a FIND Act, which is being introduced. And it is going to be reviewed hopefully in the next couple of months in the Congress. So I think it will be important if people who can support the FIND Act, you can Google it. And if you can support, but that's where our patients will need to be supporting us as well, because they are partner in our clinical care.
Got it. Thank you so much, Dr. Munir Ghesani, who is the Chief of Nuclear Medicine at Mount Sinai here in New York City and President of the Society of Nuclear Medicine and Molecular Imaging, Q104.3.
New York's classic rock, Q104.3.